it takes too much time for an abscess to develop.
Early in life, early. 1 or 2
Okay.
days will be enough in this age group because these children may be dehydrated, septic, unwell generally, so early,
Mm.
unlike adult. And
Okay.
also the resolution will be very fast.
Okay.
Okay, what do you think about this child?
Okay. This is a frontal radiograph of the
Again, suspected physical abuse.
okay, this is a frontal radiograph of both knees and legs of skeletally immature patient. The main abnormality I noted is the presence of peaking of the
Good,
medial metaphyses of the
good.
both tibia. Um, okay, with the irregularity of its margin. Okay. Suspecting physical
No,
abuse.
no fracture or periosteal
Okay,
reaction
I
could be
can.
seen, especially
Yes,
no corner fracture or buckle
yes.
handle fracture. Rule out what I want to hear. Okay, you detected the positive.
I was going to.
You didn't give me any chance, Dr. Ismail. Okay, no problem.
Okay.
Good, good. Okay, so what is your diagnosis?
Okay. Metaphysal peaking. I'm thinking of. Okay, I'm not sure. Blount disease, but
Yes, yes,
okay,
yes.
Blount
Blount
disease.
disease or congenital tibia vera, especially if the age of the child is,
He's walking a child. 2 to
yes, if
3 years.
especially if walking. Okay.
Mm.
Um, didn't write age. No
Okay.
problem, no problem.
Mm.
For example, 1.5 or 2 years or older
Mm.
age group. Okay.
Mm.
But if younger, still can be any less than 1 year, still
Mm.
it can be in the differential. Excellent, my friend. Blount disease or congenital tibia vera, one
Mm.
of the mimics of a non-accidental injury.
Mm.
Uh, I don't see the ossification center for the patella. When it appear, my friend,
I'm not sure.
about 2 to 5 years. Okay, so if
Okay.
not seen, no problem. It will not affect so much. But if seen, definitely it's above 2 years. Okay,
Okay.
excellent, excellent, my friend. Well
Okay.
done, يا boss. Well done.
Thank you.
Uh, okay, the next candidate يا شباب, easy case.
ازيك يا دكتور؟
الحمد لله رب العالمين. How are you يا boss?
الحمد لله.
Alhamdulillah. Okay. Proceed. Respiratory distress.
Okay, I am presented with frontal chest radiograph of skeletally immature patient. I cannot see the humeral epiphyses, so this is a
Good.
preterm baby. The most striking abnormality is air lucency, delineating the thymic gland, giving the appearance of angel wing sign.
Excellent. Excellent. Or
Uh,
Magnificent. I don't know, remember the name of this movie. Okay. Okay. By Angelina
um,
Jolie, by the way. Okay.
yes.
Okay.
Um, denoting pneumomediastinum. There is
Good.
also bilateral diffuse granular opacities
Good.
within both lung fields,
Good.
denoting respiratory distress.
Yes, I agree.
Uh,
I agree.
okay, there is nasogastric tube with its tip seen projecting within the I think it's
Within the
normal.
abdomen,
Yes,
possibly in the gastric air
gastric
shadow.
shadow.
Okay.
Yes, there is no pneumothorax, no pleural effusion.
Good.
Okay, normal reps. There is no pneumoperitoneum.
Good.
So,
Good. Very good.
uh, so this is a case of pneumomediastinum with respiratory distress syndrome. I'd like to convey these findings urgently to the referring pediatric clinician and
Recommend follow-up. If
and
the
recommend
endotracheal tube is placed, adjust the setting of ventilation. But actually, they removed it. Okay,
yes.
excellent, my friend. When the thymus is seen adjacent to the heart, it's called just sail sign. But if separated from the heart by this lucency, it's called spinnaker sail sign, or angle wing sign, or magnificent sign.
Mhm.
We can, I'm sorry, fasting and my voice. Okay.
Okay.
Also, we can يعني detect or confirm by decubitus as well. Increased lucency between the thymus and the heart. It's not diffuse or not pneumothorax. It will be present here, but the thymus adjacent to the heart. Excellent, my friend. You told me normal reps. This is very, very, very good remark. Remember, my friends, we have 4 emergencies in the neonatal radiograph, neonatal chest radiograph. Chest problems, pneumothorax, pneumodiastinium, okay, pneumopericardium. Abdominal problems, portal venous gas, mottled lucency, or free air, like pneumoperitoneum. Bony emergencies, fracture, ribs, or humerus. It can be an indirect sign for non-accidental injury. And the last one, misplaced lines and tubes. 4 emergencies you should rule out during assessment. Excellent, my friend. It's just a pneumomediastinum, one of the causes of barotrauma as well, one of the results of barotrauma. What do you see in this child? Neonate. No
Okay.
further history.
I am presented with frontal radiograph of abdomen of a skeletally immature patient.
Chest and abdomen.
Uh,
Okay.
yes, chest and abdomen. There is multiple dilated bowel loops with mottled appearance
Good.
along the right lower aspect.
Good.
Um,
This is the
I cannot.
commonest location, by the way. Very good.
There is a nasogastric tube with its tip in its normal position within the stomach air shadow.
Expected
There
location.
is
Good.
expected location. There is umbilical venous catheter with its tip slightly below the diaphragm, needs
Agreed.
to
Yes.
be repositioned.
To be
I can
repositioned and introduced further to avoid any portal vein thrombosis or hepatic fluid collection. Excellent. So when you advise, you mention the complication at the same time. Okay. And I think this may be the first point before mottling. Okay. Just to
Okay.
fix this item, lines and tubes, then I'll say the emergency. Good, my friend.
There is a falciform ligament sign denoting pneumoperitoneum.
Falciform ligament.
Yes.
Yes, excellent, excellent, good.
There is also I'm suspecting regular sign as well.
Where?
Along the left lower aspect. I'm not sure.
Sometimes we call this pseudo-regular sign. What do you mean by regular sign? If the wall of the gut is well seen, it means air inside and air outside. Free air, pneumoperitoneum. This is classic regular. But if air in a bowel and air in an adjacent bowel, I can see the wall also. This is called pseudo-regular. It's not pneumoperitoneum. So I think pseudo-regular. So I'm just suspecting falciform. Maybe bowel wall, and that's it. Any other
There
supportive
is
signs of pneumoperitoneum?
football sign.
Football sign, not sure. Continuous diaphragm, not sure.
Not sure.
What other
Okay.
signs? Do you see the wall of the abdomen?
Yes.
Yes, very clear. Why? Because there is a lucency. You see here, subtle lucency projected over the liver. It makes the abdominal wall clearly visualized. Okay,
Mhm.
a clear
Yes.
demarcation between the abdominal wall and the liver, it means a lucency projected over the liver. It's significant amount, by the
Mhm.
way, significant amount of free air. So two signs here of pneumoperitoneum.
Pneumoperitoneum. Yes.
Clinician is asking, how to be sure? I'm not convinced.
Lateral decubitus side.
Lateral, or is this lateral or dorsal
Dorsal.
decubitus?
Dorsal.
Dorsal decubitus.
Yes,
What do you
dorsal.
see now?
There's appreciable amount of air
Yes,
along
considerable
the
amount.
anterior.
Yes, yes,
Yes.
very good. It's a
Along the
significant
anterior
pneumoperitoneum.
aspect.
Good, good.
Mhm. Yes.
Back again, my friend. If I
There is
didn't
also
notice, if I didn't notice this pneumatosis intestinalis, and you see
Mhm.
some dilatation of the bowel loops and pneumoperitoneum, possibility could be what?
If there is no necrotizing,
No, not I don't rule out necrotizing.
oh,
I said no pneumatosis, just perforation. One of the causes, yes, perforated necrotizing enterocolitis, and the other
mhm.
one,
And the other one, perforated viscous,
yes, yes, secondary to maybe
infrastructure,
atresia, maybe atresia.
or atresia,
Okay.
yes.
Yes,
Mhm.
any atresia,
Mhm.
ileal atresia, colonic atresia, whatever. Okay. So a
Mhm.
congenital type of distal bowel obstruction followed by perforation. So perforation
Yes.
has two main etiologies. Okay.
Mhm.
Either atresia, okay, or necrotizing enterocolitis. The supportive sign for necrotizing is pneumatosis or portal venous gas, and
Mhm.
also prematurity, but I'm not sure. I'm not sure. I don't see the ossification center of the proximal humor. I just
Yes.
raised the possibility. Excellent, my friend. Excellent.
Mhm.
Don't forget to say dilated bowel loops,
The
okay?
loops, yes.
Because it's already dilated. This is the first
Yes.
phase, then necrotizing, then
Okay, right.
pneumatosis, then portal venous, then perforation.
Mhm.
Okay. And also,
So
before we
respiratory
finalize,
distress.
yes,
There
we
is
have.
bilateral respiratory distress syndrome. So I'd like
Yes,
to convey these findings urgently to the pediatric physician and
excellent.
avoid enteral food and advice for IV fluids and monitoring of the
Mm, urgent pediatric
urgent pediatric
surgical referral.
laparoscopy.
Okay.
Yes.
Even if you didn't say anything else, this will be enough. Okay.
Yes.
You will not treat. I need the parental referral. Yes. Okay. Urgent pediatric
Pediatric
surgical,
surgical.
not neonatology. Urgent
Yes.
surgery is needed. It's perforated. Okay.
Mhm.
Not
Yes.
monitoring, not follow up. Surgery. Okay.
Yes.
Well done. Well done, yeah, boss. Well done. This is very important case. Sorry,
Mhm.
I didn't bring you a clear case of pneumoperitoneum. But if you detected this subtle finding, inshallah,
Mhm.
a good point, full mark بإذن الله in this case, and a good point in your communication. Okay? Excellent, excellent. You did it well, by the way. Okay, a classic case. No history given.
No history. Okay. I am presented with bilateral frontal radiograph of both femurs and hip joints.
Yeah.
I cannot see the epiphyses of both femurs. There is the most striking abnormality
Denoting,
is denoting the
you
patient is
said
less
I,
than
huh?
4 months.
Oh, good, good, good. Because if you said, I don't see the ossification center, okay, what is the information given to
So
me? So,
yes,
yes, you said this because you want to put a certain age of the baby,
yes,
okay? I don't see,
non-ambulatory.
yes, I don't see ossification center of proximal femora, which appears at roughly at the age of 3 or 4 months. It means
Mhm.
this child is not
No,
ambulatory.
yes,
Okay, you give me this
yes.
information. Thank you. Very good. What is the next clear information?
There is a spiral lucent line, fracture line seen implicating the diaphysis of the right femur,
Good.
denoting suspected physical abuse.
Yes. In this
So I'd like,
non-ambulatory child. Very good, because it's
yes,
very difficult to fracture the femur. Very strong bone. Even if I
mm-hmm.
told you fall from the couch, not
It's not
consistent
that,
with the given history.
yes,
Okay. Diaphyseal spiral fracture with soft tissue swelling, it means hematoma. Also in my routine practice, don't forget orthogonal view.
yes,
Okay.
to check the other orthogonal view.
Yes.
So in my routine practice, I'd like to convey these findings urgently to the referring physician and keep the
Good.
child in the radiology department,
Good.
and ask for child protection services. Also, I'd like
Immediately
to
contact Child Protective Service, immediately contact the referring physician about the finding. Okay, this is 2 phone calls. What else?
mhm. I'd like to check for any other fractures and the skeletal survey and an
Skeletal
enhanced
survey. Very
CT
good.
brain.
CT brain,
Uh,
especially if the
there
child
is
has some neurological manifestation like drowsy, looking for a fracture or subdural hematoma. Very good. This will be enough. If asked more, okay, sibling imaging of the sibling is also
okay.
recommended, and plus the report should be done by 2 radiologists,
By
but no.
period,
Okay,
yeah.
excellent, excellent, yeah, boss. Well done, well
Thank you.
done. Okay, the next candidate.
Hello, Dr. Ismail.
Hello, how are you, boss?
Alhamdulillah. How are you, doctor?
Alhamdulillah, Rabbil Alamin, Alhamdulillah.
Alhamdulillah.
Okay, what do you see in this patient with respiratory distress?
Okay, I'm presented with frontal radiograph of a skeletally immature patient. First, I'd like to comment on the lines and tubes. There is a nasogastric tube with its tip is seen projected over the left hemithorax.
Okay,
Okay, so I'm suspecting that there is a diaphragmatic hernia on the left side, as
good.
I cannot delineate the diaphragmatic dome clearly. Okay,
Excellent, excellent. So we have 2 signs till now. Good.
yes,
Coiled nasogastric tip of nasogastric tube within the or project over the left hemithorax, and absent visualization of the left hemidiaphragm. Okay,
uh, okay. I'd like to comment on the tubes. Then getting back to the abnormality, I
good.
can see an umbilical venous catheter with its tip is at satisfactory position. I think it is just below the diaphragmatic, so it might need
Little further. Okay,
yes,
very good. Okay,
repositioning. The endotracheal tube is seen a little bit high,
okay, but
or
slightly deviated due to mass effects. Okay,
yes. So there is okay. This is an umbilical arterial catheter.
good.
It is positioned at T7 to 8. I think it needs
7 to 8, I think 6
okay.
to 5. So at the upper
Okay.
expected level, okay,
Yes,
borderline,
high,
and
high.
D6,
Yes,
okay,
it's
borderline,
borderline.
okay.
So getting
Oh, good.
back to the left hemithorax, there is, as I mentioned, the diaphragmatic dome is not clearly visualized. There is air lucencies within the left hemithorax, also opacification of the
You
of the
suspected diaphragmatic hernia, but most of the chest is already opaque.
yes, opaque
Why?
hemithorax. Uh, maybe the endotracheal tube in, is on the to the right. This is
No,
yes,
no.
this is
You
collapse. This
suspected
is collapse due
why
to the mass
collapse?
effect.
Yani why just collapse? Okay.
Yes, due to the mass effect.
Another. I want another. يعني answer. Also, most of the bowel loops in the abdomen opaque. Why? I'll tell you the answer. It's okay.
Okay.
Even if you see the tube here and all the hemithorax opaque, all the abdomen opaque, so this may be severe distress, and the child immediately imaged after birth, before swallowing enough air to fill the bowel, and before also breathing enough air. So
Okay.
early in life, in the first few minutes, if the child with this type of hernia, severe distress, imaging after immediately placing the endotracheal tube, any congenital lobar overinflation, any congenital diaphragmatic hernia, any CBAM, all will be seen opaque due to filled with fluid. Just after 2 or 3 hours, I see some, yes. You see here, after just
Yes.
4 or 5 hours, all bowel loops filled with gas. Okay,
Yes.
so this is an explanation for the opacity. Opacity in the bowel loops early in life because it's still filled with fluid. Duodenum can be seen, I think, after 1 to 4 hours. A small bowel can be seen up to 12 hours. So just give him enough time. Okay, very good, my friend. Very good. So the
Okay.
diagnosis of this case is
A congenital diaphragmatic hernia.
yes.
So
I
I recommend
agree. I agree. One candidate also said we have ipsilateral,
yes,
يعني,
yes,
yes, hypoplastic lung. Yes, yes, has effect. Very good, very good. Okay, immediate surgical refer.
pediatric
By the
surgery.
way, the start immature skeleton, and I can see the ossification
Yes,
center, so not term.
full
يعني,
term.
don't for yes, it's a term baby. Yes, not preterm. Okay, don't forget to say this one. Okay, let's revise the medical causes and surgical causes. What are the medical causes? If we see a bilateral symmetrical lung changes, it can be
Respiratory distress syndrome.
excellent respiratory distress, especially if preterm, no ossification center. What else?
Transient tachypnea of newborn.
Transient tachypnea, the one who born with cesarean section with lung syndrome need
Yes.
further suction. It will be resoluted within less than 12 hours. Mild distress doesn't necessitate endotracheal tube. What else?
Meconium aspiration.
Meconium aspiration syndrome, difficult delivery or post date. Usually we will see the ossification center and the cord opacities. With difficult delivery, meconium released in the amniotic fluid, aspirated by the lung, causing chemical pneumonitis. Marked opacities. Okay. And the last one, if premature rupture of membrane and chorioamnionitis, neonatal pneumonia. Okay. In
Yes.
the exam, I think respiratory stress syndrome, meconium aspiration, because these two entities necessitate endotracheal tube.
Yes.
It's severe type of distress. Bilateral, symmetrical. Surgical causes, if unilateral, like
Congenital
congenital
diaphragmatic
hernia.
hernia.
What else? CBAM,
CPAP.
excellent.
Congenital.
Bubbly lucences, or even opacity, but diaphragm should be intact. Okay. And another sign, my friend, you see here, abdomen is a scaphoid, devoid of gases, and the scaphoid abdomen. It means the bowel gases is not present in the abdomen. It's present in the chest. In a CBAM, the abdomen will be normal, bulging abdomen. Good. Other one?
Congenital lobar emphysema.
Congenital lobar emphysema or overinflation, the recent term. The last one, but less likely, maybe just pulmonary sequestration. Excellent, excellent, my friends. This is a follow-up of this case. Okay, and after treatment, development of pneumothorax that resoluted later on and developed on the other side. Okay, barotrauma. This is barotrauma. Okay, good, my friends. Now, MSK, what do you see? Suspected physical abuse.
Okay, I'm presented with a frontal chest radiograph of a skeletally immature patient. I can see the femoral epiphysis in this radiograph.
Okay.
So I'd like to check the ribs as the patient is suspected physical abuse. I cannot see any rib fractures.
Good. This is number one.
I can see there at the posterior ribs there is widening at the posterior ribs at the junction.
Junction. What junction you mean?
This is rosary beads. But I'm trying.
Yes, it's a rosary piece. Okay.
Yes.
Describe it, يا boss.
Yes.
Anterior, not posterior. Anterior.
Yes.
At the costochondral junction. Okay.
Costochondral junction.
Bulging
Yes.
of the anterior end of the ribs at the expected site of costochondral junction. Impressive of rachitic rosary beads. Okay. I'll correlate with the age of the patient and the nutritional states and any يعني other radiograph. Even in
radiographs.
the radiograph, you see something like a metaphyseal cupping and fray. And also, I recommend any imaging of the extremities. Okay, yes, along bones, wrist or knee to determine the other signs of rickets. Okay, this is not a callus formation. Callus formation can occur anywhere, especially posterior ribs or at the angle, or even anterior ribs, but away from the costochondral junction. Okay, so this is a rachitic rosary, one of the mimics of suspected physical abuse, non-accidental injury. Well done, ya boss. Well done. Thank you, my friend.